Good evening, everyone. Thank you for joining us for this American Foregut Society's first webinar. This is a part of our bi-monthly webinar series. Today's focus of this webinar is diagnostic assessment of patients who have GERD symptoms. Our presenters today are Dr. Crystal Lynch and Dr. Prakash Gayawali. Dr. Gayawali is professor at WashU and director of neurogastroenterology and mortality division there. Dr. Lynch is assistant professor and director of GI physiology lab at University of Pennsylvania. Format of this webinar is Dr. Lynch will present her presentation, followed by Dr. Gayawali's presentation. At the end of that, we will have question and answers. Please type in your questions in Q&A options, and we'll have those answered at the end of both the presentations. Now, I'll hand over to Dr. Lynch.
Great, thank you so much. Good evening or afternoon, everyone, and thank you to AFS for having me today. I'm glad to kick off the webinar talking about GERD, current diagnosis and evaluation. I'm Crystal Lynch at the University of Pennsylvania, as was previously mentioned. I have no relevant disclosures for this lecture. So GERD, as we know, is the presence of troublesome symptoms that develop due to reflux of gastric contents into the esophagus. We're well aware that the chronic condition is highly prevalent, and we see it in up to 28% of patients in North America, 23% in South America, 8% in East Asians, and variable across the world. But we do know that this does result in significant global morbidity as well as cost. GERD is really multifaceted. And when we think about GERD and we're trying to put together a patient with GERD, there's so many factors that we try to take into account. And these are examples of some of the things that we think about. And today I'm going to try to present the framework with, that I use to think about every patient with suspected GERD. So I largely think about it as pieces of a puzzle. First, of course, the patient's clinical presentation. Next, an evaluation of the patient's anatomy, the patient's reflux burden on pH testing, as well as esophageal clearance factors. So first, we'll start with clinical presentation. So we know the classic symptoms of reflux. Patients come in with liquid regurgitation, as well as heartburn. But we also see a lot of patients with atypical symptoms. So everything from cough to shortness of breath, burning mouth, ear pain. These are things that are not typically from GERD, but maybe from GERD. And so when patients have classic symptoms, we obviously have a higher suspicion. What about a PPI trial? I definitely include this in clinical presentation because it's a low cost and low risk method. And patients often have completed a PPI trial prior to presenting to a specialist. A PPI trial doesn't have the best sensitivity and specificity, ranging around 70% and 44%. Next, we'll look at anatomy. So as a gastroenterologist, clearly this is typically done by endoscopy, but I also will look at barium swallows and often CT scans. So on our endoscopic examination, the first thing I'm going to look at, of course, is for esophagitis in the distal esophagus. And so we have the LA grades here. Grade A are small mucosal breaks. Grade B consists of mucosal breaks greater than 5 millimeters. Grade C has mucosal breaks that bridge the top of 2 folds. And grade D, the most severe, is when the mucosal breaks bridge the top of 2 folds and encompass greater than 75% of the esophageal circumference. So how do we apply this? When I think of grade A, I remember that that can be seen in normal patients. Grade B is sort of a gray zone where this may be some evidence towards reflux, but it's not necessarily pathologic for reflux. And grade C and D, of course, are highly concerning for reflux. Here you can see 2 of my patients, one on the left with grade B esophagitis with mucosal breaks that are certainly longer than 5 millimeters, but not bridging 2 folds. And on the right, we can see that these breaks are bridging multiple folds. What else do we look for in endoscopy? Of course, Barrett's esophagus, as well as peptic strictures, both of which are highly concerning for uncontrolled acid disease. We know that the relationship between acid exposure and the severity of mucosal damage is clear in multiple studies. This is one such study from 2009. And on the y-axis here, we have the total esophageal acid exposure time on pH testing. And the blue dotted line is where they hit 6%. So above 6% is typically considered abnormal. And we'll touch on that in a little bit. And I think Prakash will talk about testing as well. But you can see sort of I've highlighted that patients with grade C and D esophagitis largely had abnormal esophageal acid exposure times, as well as Barrett's esophagus. So moving on in anatomy, we also evaluate if the patient has a hiatal hernia. You can see on the left one during endoscopy, as well as on a barium swallow. The GE junction is critical to evaluate in any patient in whom you have concerns for Gerd. So this is a grade 1 flap. And you can see here, this is the retroflex view of the endoscope. And there is a well-defined ridge that is closely approximated to the retroflex endoscope. That would be considered a grade 1 flap. In grade 2, the ridge is not well defined, but we aren't really seeing a space between the endoscope and the mucosa. In grade 3, there is often a space as you move the endoscope, and grade 3 is almost always associated with a hiatal hernia. And then in grade 4, we can see a large hiatal hernia here. When you look at the distribution of grades, the lined bars are patients with reflux and the black bars are control patients. And you can see that the patients with reflux most likely had grade 4 flaps, some of them grade 3, and very few grade 2. So in summary for endoscopic findings, I would say that we have conclusive evidence for pathologic reflux in 4 situations: grade C esophagitis, grade D esophagitis, Barrett's esophagus, and peptic strictures. For borderline or inconclusive evidence, I would put grade B esophagitis there. And for supportive evidence, I would say a large hiatal hernia or patients with grade 3 or grade 4 Hills. So next we'll look at reflux burden via pH testing. So when I'm trying to figure out what sort of pH testing to order for the appropriate patient, I first try to categorize the patient into a low likelihood of Gerd or a high likelihood of Gerd. And the factors I used to sort of make that categorization were things that we just discussed: how they presented, what their GE junction looks like, etc. When patients have a low likelihood of Gerd, I recommend wireless pH testing off of PPI. And when they have a high likelihood of Gerd, we typically order pH impedance catheter-based testing. So to first talk about wireless testing, the wireless probe is reflux monitoring done off of acid suppressing therapy. This is a 48-hour at minimum test. It can be extended up to 96 hours, and we can obtain symptom correlation to acidic events. So you can see on the bottom left, this is the delivery catheter with the pH probe on it. And on the right is my patient in whom we've placed it via suction. And so for the wireless probe, you're obtaining information at one point in the esophagus. So if you think about it, there's many advantages of this. It's catheter free, so minimal discomfort. After the procedure, there's no activity limitations, and we can obtain up to 96 hours of data. The disadvantages are also clear. It requires endoscopy and anesthesia. The pH data is limited to one location. There's a higher cost because the endoscopy and anesthesia are required. And there's also the potential for undetected early dislodgement where, before 48 hours, before 96 hours, the capsule deploys, and then you're stuck basically analyzing stomach data. So catheter-based pH impedance testing can be done on or off of therapy, but is most commonly done off of PPI therapy. The most common test prior to laparoscopic anti-reflux surgery is a pH impedance testing off of PPI. So remember that the pH impedance catheter has dual pH sensors in the esophagus and stomach, and it also has impedance bolus sensors along the length of the catheter. On the right here, you can see a depiction of how it's placed transnasally and threaded through to the bottom of the stomach. So the advantages are low cost, no anesthesia. You get both pH and impedance data as dual channel. But the disadvantages are pretty logical. Limited activity post placement, I would say. We tell patients to do normal things, but patients are not going to the gym with this tube taped to their nose. There's certainly some catheter discomfort. And typically patients tolerate this for about 24 hours, so that's our data limit. And also, catheters can migrate, especially when you have patients who may have cough or other atypical symptoms. We can see the catheters move, and patients also can inadvertently remove them sometimes during sleep. These are not stapled or sutured in place by any means. So what do we look at when we get this huge report of all of these numbers on advanced pH testing? So the main primary outcome is acid exposure time. It's reproducible, it's easily automated, and we've seen studies where it's predictive of response both medically and surgically. So greater than 6% is abnormal for the AET. Less than 4% is considered normal or physiologic, and between 4 and 6% is sort of the gray zone. So greater than 6% is really the number to keep in mind for the primary outcome of AET. There are a couple secondary outcomes we look at as well. Reflux episodes. The number of reflux episodes greater than 80 in 24 hours is considered abnormal. Less than 40 physiologic, and then we have our gray zone. I will say though that the clinical relevance of the number of reflux episodes is unclear. So, if you have greater than 80 reflux episodes, that in itself is not necessarily helpful, but we use it more as an adjunct measure when the AET may be inconclusive in that gray zone. Another secondary outcome that we look at that can be very helpful is symptom score. So the SI and the SAP. The symptom index, SI, is pretty simple. It doesn't consider the number of reflux episodes. It looks at the symptoms, and there's a 2-minute correlation threshold and a 50% threshold for being positive, meaning that if the patient reports a symptom within 2 minutes of an acidic reflux event, that's considered a positive correlation. And if over 50% of the episodes are like that, it's considered a positive symptom index. For SAP, it's a little more complicated. So SAP considers the total number of symptom events and reflux episodes, and it is positive if the p-value is less than 5%. So you can see how the SAP really would be optimized off of PPI, because theoretically you would have more symptom events and more reflux episodes. Both of these scores do predict response to both medical and surgical therapy. So in summary, for the reflux burden, I would say that conclusive evidence for pathologic reflux is when the AET is above 6%. Borderline or inconclusive evidence would be our gray zone. And then evidence against pathologic reflux are when the AET is normal or the reflux episode number is low. And then some supporting evidence would be our positive symptom association indexes and when the reflux episodes are elevated. So lastly, we'll talk about esophageal clearance factors. So this is an example of an esophageal manometry, and manometries can give us really valuable information in patients who present with acid reflux symptoms or a question of acid reflux. Manometry provides an evaluation of peristalsis and esophageal clearance. Additionally, postprandial manometry can assess for significant behavioral disorders. So first we'll talk about our manometry evaluation. So nowhere better to start than the Chicago classification. The Chicago classification has been updated as of November 2020, but I sort of have a simplified depiction here. So when the median IRP is abnormal, patients either have achalasia or esophageal obstruction, when the lower esophageal sphincter is not relaxing appropriately when the patient swallows. When the lower esophageal sphincter is relaxing normally and the median IRP is normal, patients can have a variety of diagnoses, including spasm and jackhammer, absent contractility and ineffective motility, as well as normal. So looking at absent contractility, that's 100% failed swallow, so no appreciated peristalsis. And ineffective motility, which is now defined as at least 80% or more ineffective, or the old category of fragmented swallows, or at least 50% failed swallows. We know that esophageal hypomotility correlates with an increased acid burden. And so these are important things to keep in mind when we're trying to put together the whole picture for a patient. Additionally, we need to make sure that other causes are ruled out. So Chan et al. Did a study in 2011 that looked at about 1,000 patients undergoing laparoscopic anti-reflux surgery, and their preoperative manometry testing was reviewed. So 1.3% of patients had severe hypomotility, 3.2% of patients had aperistalsis, 1.5% of patients had LES dysfunction, consistent with esophageal obstruction, and 1% of patients had achalasia. So yes, these numbers seem very low, but with patients with hypomotility and aperistalsis, these patients should be considered, or at least have a discussion about a partial wrap. So that's 4.5% of patients who require additional discussion. Additionally, 2.5% of these patients had an absolute contraindication for laparoscopic anti-reflux surgery that clearly would not help them if they have achalasia or achalasian evolution. And so it's critical to make sure that there's not other findings that need to be considered prior to having any sort of intervention. Additionally, postprandial manometry can assess for significant behavioral disorders, such as rumination, as seen on the left, and supragastric belching, as seen on the right. So there was a study by Yadlapati in 2018, and they looked at solid phase meal manometries in PPI non-responders, so patients whose symptoms did not respond to PPI. And there were 94 patients. This was a retrospective single center study. And what they found is here. So in the blue is normal, so 34% of patients had normal manometry, and the orange had evidence of reflux. But gray and yellow, gray is 42% of patients had supragastric belching, and 20% of patients had rumination syndrome. So this is really marked because overall, 62% of patients had a behavioral disorder. We know that for behavioral treatment, we focus on diaphragmatic breathing, speech therapy, hypnosis, acupuncture. We're not doing further workup for pathologic acid reflux typically in these patients. So it's really important to, it's case by case, but making sure that these are things that we're considering and keeping in the back of our minds when we're working these patients up for GERD. So overall, in summary, I would say for evidence for GERD, 3 of our important tools are endoscopy, pH impedance, or other pH testing, and manometry. Conclusive evidence for pathologic reflux, we talked about the endoscopic findings and the AET greater than 6%. For borderline or inconclusive evidence, that's LA grades A and B, as well as the gray zones for AET and reflux episodes. For supporting evidence, we have large hiatal hernias, positive SI, positive FAT, high number of reflux episodes, and then also esophageal hypomotility, absent contractility. And then for evidence against pathologic reflux, that would be a low or normal AET, a low number of reflux episodes, and then of course, any other explanation for these symptoms that may be found on other workup. So that's it for my talk. If you have any questions, please feel free to add them to the Zoom chat Q&A, and they'll be addressed at the end of both lectures. And I'll hand it over to Prakash. Thank you.
Thank you so much, Chrissy. That was an excellent presentation, and there will be some overlaps with my presentation, but I'm going to try and focus on the refractory end of the spectrum. So patients whose symptoms persist despite seemingly adequate management, or patients who may need to move to additional or some other kind of therapy beyond, beyond the initial treatment. So the overall intent is to take somebody from esophageal symptoms to symptom improvement. Important to recognize that the esophageal symptoms that the patient reports may not be what they seem. And that's very important to recognize. And Chrissy touched on this a little bit, because somebody who says they have discomfort in their chest, you think about reflux, but sometimes that is the opposite of reflux, achalasia. Somebody may say they have regurgitation, that's usually reflux, but sometimes that may be rumination, should be treated completely different from reflux. So it's important to recognize that esophageal symptoms need to be characterized. The appropriate testing has to be applied. The test results have to be analyzed and interpreted, and appropriate management needs to be chosen. And we have several classification schemes and other criteria that help us phenotype these esophageal disorders. It's important to recognize that these are guides. They are not necessarily gospel. And you have to interpret some of these guidelines sometimes. Past investigation, past treatment may also influence how these tests are analyzed and how the patient is phenotyped. And a very important point, there may be overlap between disorders. So somebody with reflux disease could have functional esophageal disease on top of the reflux. And important to recognize, identify, and treat both the disorders, because if you just treat one, the patient's not going to get better. So Chrissy is about this, but when reflux is suspected, if somebody has esophageal symptoms, you go through a PPI trial, and if the trial is positive, the patient gets better, no alarm symptoms, you treat as reflux. If the patient doesn't get better, they have alarm symptoms, or prior to definitive management, which includes anti-reflux surgery or invasive anti-reflux measures, you go for further testing. And Chrissy very nicely demonstrated what constitutes unequivocal reflux evidence with extraesophageal symptoms, because the likelihood of true reflux disease is low. When somebody has primary extraesophageal symptoms, you may jump straight to further testing rather than go through the PPI trial stage. So you want to move a patient from unproven Gerd, that's the symptomatic patient, to proven Gerd, but a PPI trial is not enough to make a conclusive diagnosis of proven Gerd, not enough for unequivocal diagnosis. And the overlap of functional GI disorders with reflux disease can influence if a patient gets better on a PPI trial or not, whether they have pathologic acid reflux or not. So you can see that if there is IBS, functional dyspepsia, or depression, the likelihood of a patient saying they're better on a PPI is not as good as if they just have pathologic acid reflux. Now, definitions are also important, and it's important to distinguish between refractory Gerd and refractory heartburn, or refractory chest pain, or refractory whatever your symptom is that you're evaluating the patient. So when you say refractory heartburn or refractory symptom, it means that the symptom is not responding to your empiric PPI trial. And the typical duration before you give up on it is about 12 weeks. Now, refractory Gerd implies that you know for a fact that the symptoms are due to reflux of gastric content and the patient is not responding to stable dose PPI. So the implication of refractory Gerd is that symptoms are from inadequate management of reflux. So that's a proven Gerd patient. Whereas when the symptom is refractory and you haven't done conclusive testing, symptoms may or may not be from reflux. So again, unproven Gerd, proven Gerd here, refractory Gerd, using some of those Lyon consensus criteria that Chrissy talked about. And you have to distinguish or differentiate refractory Gerd, proven Gerd from no Gerd. So if you go back to our reflux pathway, at the outset, when we are suspecting reflux, if the patient has obstructive symptoms or if there is a suspicion for obstruction, you may go down the obstructive pathway or atypical pathway. If the endoscopy demonstrates conclusive evidence for reflux as suggested on the Lyon consensus figure, you treat as reflux or escalate management if they haven't been getting better, and that's proven Gerd. Now, on upper endoscopy, you might find features that lead you down the obstructive pathway as well. Some findings in endoscopy may lead the investigation down a motor disorder pathway, for instance. So there is overlap between the reflux pathway and the obstructive pathway. The obstructive pathway starts out when somebody has dysphagia with or without chest pain and bland regurgitation. Here you're looking for an obstructive disorder in the esophagus. And you can see here that on upper endoscopy, there is overlap with reflux because mechanical obstruction can result from esophagitis and from strictures, which is actually part of reflux disease. So it's important to make that distinction with the investigation. Obviously, if endoscopy is normal, you do physiologic testing, high resolution manometry, barium, flip, and here you're trying to look for issues with esophageal emptying, which is in some ways the opposite of reflux. Now, there may be findings on endoscopy that lead you directly to the presence of a motor disorder. And you can see some of the findings in endoscopy. So endoscopy is an important initial step, despite the fact that the yield for a conclusive diagnosis of reflux is relatively low. So in a treatment naive patient with typical symptoms, that number is somewhere between 30 and 40% that you will find erosive esophagitis. Okay, so you've already seen this conclusive evidence with reflux and endoscopy, borderline inconclusive evidence, and the importance of recognizing some of these features is that if you have conclusive evidence, you do not need the next step. You have demonstrated evidence for reflux and you can move on to management. There are a couple of other steps if you're going down an invasive route for management, and we'll touch on this in a little bit. So here are the indications for reflux monitoring. So persisting symptoms, so you have somebody with unproven Gerd and you want to look for evidence of Gerd. So prior to invasive procedures, persisting symptoms despite invasive procedures, symptoms following treatments that are typically associated with reflux, and an investigation of some of these atypical syndromes, belching and regurgitation syndromes. Chrissy has talked about the value of one versus the other, but you can use either option, wireless pH or pH impedance, in high pretest likelihood of Gerd, because sometimes you do these tests based on the convenience factor. And if your test is highly likely to be positive, it doesn't matter which test you do, as long as you do it off PPI and there is pH monitoring involved, your test is likely to provide the results that you're looking for. Now, these are some of the situations where wireless pH has better value than pH impedance testing. Chrissy touched on this a little bit, but one scenario, the third one listed here, you might want to think about a little bit. So if you have somebody with a high clinical suspicion for Gerd and you catch the patient on their best day with a 24-hour study, then your test might be negative. Those are the patients that sometimes you need to bring back and do a prolonged 3 or 4 day study. And like Chrissy said, it is useful to do a prolonged monitoring if you are trying to rule out Gerd. If you think the person does not have reflux disease and you want to rule out Gerd, a prolonged monitoring is a good test. Now, if somebody has infrequent symptoms, you're not expecting their symptom to occur every day or frequently every day, and you need reflux symptom association, again, wireless. pH impedance on PPI, only do this for refractory typical or atypical symptoms in known reflux disease. And your intent of studying these patients on PPI is to see if their PPI management is adequate, or if you need to move in some other direction, or if there's overlap with one of the other disorders that we talked about. Now, some of the other situations where a pH impedance is better than a wireless pH study are listed here. So respiratory symptoms, belchers, rumination syndrome, or increased belching, persistent reflux following certain anti-reflux procedures. And you can see here that most of these tests are done off PPI. Well, advantages and disadvantages, again, this is a little bit of a repetition, but just a couple of points to bring out here. Wireless pH monitoring, there is a caution with pacemakers and defibrillators. And the analysis paradigms are not very well studied. The newest paradigm that we've been using is the concept of dominant versus concordant days. So you look at the acid exposure for each day. And if you have several days, more than 2 days of the same pattern, that's the dominant pattern. You don't find too many people with concordance, all 4 days the same. So if you have 2 days or more of pathologic acid exposure, that means that that person likely has abnormal acid burden. If you have 1 day abnormal, 3 days physiologic, that's a physiologic acid exposure with 1 bad day. So there is some interpretation involved. Catheter-based, well, the sensitivity for detection of reflux episodes, it's higher than with pH alone, because you can detect reflux episodes that do not have significant acidic content. So reflux symptom association is better. And more importantly, some of these novel neurometrics can be assessed. But manometry is required for placement. And most importantly, the last point here, automated evaluation of pH impedance studies is not reliable. It requires manual interpretation. You have to look at every single episode that the automated analysis has identified and decide if that is a true reflux episode or not. And we recently published the Wingate consensus document in CGH, and that describes how you identify reflux episodes. What about biopsies? So you can have several reflux findings on biopsy, but the problem with biopsy is you can differentiate erosive esophagitis from functional heartburn very easily. But the two conditions in the middle here, non-erosive reflux disease and reflux hypersensitivity, are very difficult to differentiate just on biopsy alone. And indeed, from the Diamond study, biopsies both at just above the squamocolumnar junction and 2 centimeters above the squamocolumnar junction, they just had modest performance characteristics in predicting Gerd defined on pH monitoring. Now, if you do electron microscopy, you can find these dilated intercellular spaces, and that is very good evidence for reflux disease. It can differentiate true reflux from functional heartburn and controls, but the problem is that it's not as accessible and it's not something that is feasible in every case. So routine histopathology is not conclusive as a standalone test. You heard about reflux symptom association, the 2-minute rule, and the 2 indices. There's evidence to show that those with symptom association, a positive symptom association, do better than those with negative, but standalone symptom reflux association, again, you can see the area under the curves in this very nice study from 15 years ago now. The performance characteristics are modest at best. Now, if you have acid exposure positive and symptom reflux association positive, that cohort does best with anti-reflux therapies of any kind compared to the other groups. So when present, reflux symptom association increases confidence in reflux. Now, what about baseline impedance? This is something you can extract. This is a newer metric that you can extract out of pH impedance monitoring. It's the actual impedance value at rest when there is no reflux episode, no swallow. And for convenience, this is extracted during the nighttime hours when the patient is asleep, and so does not have any confounding artifacts or other swallow-related activity. Indeed, the lower the baseline impedance, the higher the likelihood of pathological reflux. And this is thought to be a marker of longitudinal injury, not just cross-sectional information that a pH study provides. And as you can see here, the lower the baseline impedance, the higher the acid exposure. There's a very nice correlation between the two. Now, this has been taken a step further in developing this mucosal integrity balloon. This was the brainchild of Mike Vasey from Vanderbilt. He implanted impedance electrodes on a balloon. Why on a balloon? Because the balloon can be distended, can be placed after endoscopy in a sedated patient, and can be distended so there is good contact between those electrodes and the esophageal mucosa. And the impedance recordings from these multiple impedance sensors can be generated into a heat map that looks like this. So you can see the greens in the mean high mucosal impedance and normal. This is reflux. The red means low impedance, and this reflects the distal esophagus. And this is eosinophilic esophagitis, a condition that can sometimes confound the evaluation. And impedance is low throughout, up and down the esophagus in that condition. So you get a read out. So if you chart the impedance value along the length of the esophagus, so x-axis is centimeters above the squamocolumnar junction, you see a flat line at the normal range in a non-GERD patient, a flat line in the abnormal range in the EOE patient, and a curve that has a nice slope with lowest values at the bottom and higher values up as you go up the esophagus in patients with reflux disease. And indeed, in somebody who has no reflux, a patient with functional heartburn, you get a blue out that looks like this. So this is newer technology, needs further study. Now, there are a couple of other metrics that, one other metric that is that we're going to talk about, the post-reflux swallow-induced peristaltic wave. So this is a reflux episode on a pH impedance study. And in a healthy individual, within 30 seconds, you can have a primary swallow that brings saliva to the distal esophagus to neutralize the mucosal acidity of the reflux episode. And you can actually count the number of PSPWs that follow a reflux episode and calculate the PSPW index. This is a newer metric, and our group has demonstrated that the likelihood of a PSPW index being high is partly dependent on the esophageal motor pattern, on high resolution manometry, and the lower the PSPW index, the higher the total acid exposure, the higher the supine AT, the higher the upright AT. So there's a relationship there. And indeed, the PSPW index can phenotype reflux disease into various categories as shown by the Italians. Now, the baseline impedance can also do that. So these are the two neurometrics that may have some value in segregating true reflux from non-reflux situations. You can see that the value better in the top table where erosive esophagitis is segregated from functional heartburn. You don't really need that in clinical practice because the erosive esophagitis is definitive. Doesn't perform quite as well in patients who do not have erosive disease. And indeed, the PSPW continues to be studied. These new metrics continue to be studied. So where do they fit in? As adjunctive metrics, as Chrissy demonstrated. So biopsies, mucosal impedance, MNBI, PSPW can fit in here. Now, manometry, remember that one of the most important roles of manometry in reflux disease is to rule out achalasia, in addition to making a diagnosis of these non-reflux syndromes. But in the patient who needs additional management, it is also useful for assessment of esophageal peristaltic performance and for assessment of the morphology and integrity of the esophageal gastric junction. So this is the esophageal gastric junction. Conventional analysis looks at the intrinsic lower esophageal sphincter, but we don't usually take into account the inspiratory diaphragmatic crural contraction. This is a standard manometry, conventional manometry wave. You can see the variation of the lower esophageal sphincter pressure at rest with respiration. That's the intrinsic pressure. That's the diaphragmatic crural contraction. So there is a new high resolution manometry metric known as the EGJ contractile integral, esophageal gastric junction contractile integral, that may have some value, again, modest performance characteristics in determining esophageal acid burden since this functions as a measure of the barrier between the stomach and the esophagus. Here's an Italian study that shows a similar modest area under the curve in predicting esophageal acid burden on a pH and a pH impedance study. Now, with manometry, you can also characterize the morphology of the esophagogastric junction. So type 1, no hiatus hernia, diaphragm and intrinsic LES at the same level. Type 2, less than 3 centimeter separation. Type 3, 3 or more centimeter separation. The bottom one, the diaphragm has not been traversed. And these different patterns can predict whether the reflux burden is going to be normal or abnormal. And it gets more abnormal as you go towards the higher subtypes, so type 2 and 3. And if you look at the proportion of patients between healthy controls and GERD patients of these 3 subtypes, you can see that healthy controls rarely have a hiatus hernia, whereas GERD patients, you can have about a third with a hiatus hernia. Hiatus hernias are part of the pathophysiology of reflux disease. Now, esophageal body, Chrissy talked about esophageal clearance. This is a weak swallow, failed swallow. But an important point to remember is that you can assess for what's called contraction reserve, doing this very simple maneuver known as multiple rapid swallows. Give a patient 5 rapid swallows in the supine position of 2 ml water in rapid succession. And in many instances, if there is contraction reserve, you will see that the contraction sequence that follows the 5th swallow has higher contraction vigor than the single swallows. This is called presence of contraction reserve. And our group has demonstrated that if you have contraction reserve in the setting of borderline hypomotility or hypomotility disorders, the likelihood that contraction improves after anti-reflux surgery is high. These patients have a lower likelihood of developing post-fundoplication dysphagia. What about barium radiography? Great for identifying anatomy at the esophagogastric junction. Hiatus hernia, strictures, barium pill swallow, and these are all very useful. You can see an axial hiatus hernia at the top, a paraesophageal plus axial at the bottom on the left side. The problem is you cannot use barium to diagnose reflux. So these were 20 patients with reflux symptoms, half of which had reflux on esophagogram, the gold standard with pH impedance. The likelihood of pathologic acid exposure was no different between negative esophagogram and positive esophagogram. Total acid exposure was the same. The height of reflux and impedance was the same. And the total number of reflux episodes was the same. The sensitivity of barium for diagnosis of reflux is 46%. Please don't use it. Please don't pay regard to reflux into the thoracic inlet that is sometimes reported in a barium study, because that will not help you manage the patient. If you have somebody with a hiatus hernia on the barium, that is adjunctive evidence for reflux, but not all hiatus hernias are associated with reflux, and not all reflux patients have hiatus hernias. So manometry, adjunctive evidence for swaying the decision towards or away from pathologic reflux. Okay, so now you have your patient who has refractory symptoms despite PPI therapy. We've talked about how you can segregate these patients into unproven GERD or proven GERD. And if they have proven GERD, their symptoms by definition are refractory GERD symptoms. They are refractory GERD. This is how you would evaluate these patients. We've talked about how proven GERD should only undergo pH impedance monitoring on PPI, whereas the unproven patients are tested with any of these tests off PPI. Sometimes repeat endoscopy and manometry are required to diagnose these adjunctive conditions that can mimic reflux disease. You may have GERD evidence on the one side and no GERD evidence on the one side and no ongoing GERD evidence. And then you might find GERD evidence. So if you find GERD evidence on the unproven side, you treat the patient, they don't get better, then the patient automatically goes into the refractory GERD category. And if there is GERD evidence in the proven GERD pathway, when pH impedance monitoring is performed on PPI, that is the patient with true refractory GERD. What do you do for these patients? The usual stuff: lifestyle adjustments, optimize PPI therapy, increased dosing, more potent PPI. PCABs may be available in the future. hopefully they're available in Asia. Then if the patients are still not better, you can go for adjunctive therapy. Baclofen is an agent that can reduce reflux episodes. Some topical mucosal protective agents, Gaviscon with alginate, for instance, can help symptoms. Nocturnal H2 receptor antagonists have been mostly disappointing because they are subject to tachyphylaxis and the benefits don't last a few weeks. And if the patient has been adequately investigated, this is the point where you would go for invasive GERD management. So several options available here. If the patient's obese, you can consider a gastric bypass, which is a very effective way of treating reflux disease. You can see the other options listed here. What about the other side? No GERD evidence. In a patient with unproven GERD, these patients may have non-GERD esophageal disorders or non-esophageal disorders that may need to be addressed. In patients with proven GERD and no ongoing GERD evidence, they may have overlaps of some of these disorders in their picture. So they may have more than one condition that is ongoing. So this is standard GERD management. So acid manipulation of some sort combined with lifestyle adjustments. And it's when standard management fails, so the patient has alarm symptoms, that you go for GERD confirmation. And you can see that the availability of tools is slightly higher at the tertiary end compared to the primary and secondary end. The more atypical the symptom, the higher for documentation of abnormal reflux burden prior to long-term GERD management of any kind, because many of these patients with atypical symptoms do not have true reflux. Baclofen is an adjunct. If you have these mimickers of reflux, sometimes these adjunctive approaches help. Diaphragmatic breathing can actually help reduce numbers of reflux agents. There are a couple of newer agents, the PCABs, potassium competitive reflux blockers, vonoprazan, and then colsevelam, which is what IW3718 is. It can reduce bile reflux, but by binding bile in the stomach. Now, it is at this point that you would consider some of these more invasive options that we have talked about. So surgical therapy, endoscopic therapy. Not too many people are doing anti-reflux mucosectomy, and some of the other novel approaches like stimulation of the LES and the Muse procedure have gone away, probably for the better. But anti-mucosectomy, some people still do it. This works by creating a stricture at the esophagogastric junction, not a very good way of treating reflux, but some of the other options have value. And with that, I'm going to finish. Thank you very much for your attention, everybody, and happy to take any questions. I'm sure Subhash will be delivering these questions to us. I'm going to stop share.
Thank you so much, Dr. Gayawali, and thank you, Dr. Lynch. We were taking questions on the Q&A part of the webinar. Some of the questions we already tried to answer, but now since we're done with the presentation, we will answer those questions live. Since Dr. Gayawali's talk is fresh, I will post Dr. Gayawali's question first, and then we'll come back to Dr. Lynch and kind of go back and forth. Our first question is from Dr. Parkman. Is post-reflux peristaltic wave index can be calculated on a commercially available software, or do you have to do it by hand?
You cannot do it on a commercial software. It is all manual, and there's a lot of variability even among experts in what is designated a post-reflux swallow-induced peristaltic wave or not. So it is not quite ready for prime time. It can be done if it's positive. If you find many PSPWs, the likelihood of the patient responding to usual simple treatment, but not ready for prime time.
Similar questions regarding MNBI or basal impedance. Is it ready for prime time, or can it replace with other parameters?
Baseline impedance is a complementary tool, but that is one of those metrics that actually can be calculated using commercial software. So all the high resolution, all the pH impedance manufacturers have an option of how to calculate mean nocturnal baseline impedance. It turns out that you do not need to use the Italian method of taking 10 minutes every hour for 3 hours. You can calculate the baseline impedance for the entire recumbent period, and that is quite accurate. And the confounders there are that if there is esophageal dilation, for instance, or if there is content in the esophagus, that will falsely lower the mean nocturnal baseline impedance.
The commercially available Medtronic's one calculates MNBI by itself. How much confidence do you have in that versus collecting 3 separate intervals?
There is a study from Daniel Sifrin's group. He's one of the leading physiologists in the world, and he compared the entire nocturnal period to the 3 10-minute periods, and there was really no difference in the values. So if you're going to use MNBI as an adjunctive tool, this is mostly necessary if the acid exposure is not conclusive. In that group, you can use MNBI for the entire period. And the Medtronic pH impedance software does have an option of pulling that out from the study. It requires calling the rep. I don't think it's very intuitive, but yes, I have pulled it out, given studies.
And one more question on the same, looks like that's a hot topic, is what's the normal value for MNBI and number of reflux measured on impedance?
Okay, so MNBI, again, very, very good questions, okay? The published data is a little too high. So 2292 is what the Italians reported. That's a little too high. The true upper threshold of normal is somewhere between 1500 and 1700. So values around 18, 1900 are probably within normal range and are not really low. You capture a lot with the Italian threshold. And I'm sorry, what was the second question?
What's the normal number for impedance measured reflux events?
Numbers of reflux episodes. I know of only one study that used good methodology. It was a post hoc analysis of data from the MSA study, from the magnetic sphincter augmentation study, where it was compared to BID PPI. And so that data was analyzed post hoc by our group and by the Mayo Scottsdale group. And we demonstrated that patients who got their numbers of reflux episodes to about 35, so below 40, had good satisfaction with management, regardless of whether they were managed with BID PPI or with MSA. And in the BID PPI arm, remember that does not reduce reflux episodes. Those with reflux episodes more than 80 had good response to crossover links procedure placement. So that study is now published in Gut, in the journal Gut. So that seems to validate the Lyon criteria, where less than 40 is physiologic, more than 80 is definitely pathologic, and numbers in between are not completely conclusive. And there is one other study in Gut, the normal international pH impedance study, where normative data was established. And even in that study, the median normal value is below 40. And there were some normals that were in that 40 to 80 range. So more to come on this, but for now, I think the Lyon numbers are probably validated.
Thank you. Question for Dr. Lynch from David Choi. During your endoscopic evaluation for a patient who has GERD, what are the additional assessments would you recommend during the endoscopy, such as evaluating LES and so on and so forth, for patients who have long segment Barrett's or esophagitis?
So certainly during endoscopy, we'd evaluate for esophagitis and long segment Barrett's. And if you saw those together, definitely would optimize acid suppression and then repeat endoscopy to make sure that you have a clear view and clear biopsies of what's being seen there. Other things we see on endoscopy will include like the Hill grade, we'll look at that. We'll look for a large hiatal hernia, we'll look for peptic strictures. And in some cases, sort of, depending on the case, you may consider adding endoflip, but there's, that's not really a strong indication. But otherwise, I think I find the most complementary testing to be manometry and pH impedance.
Thank you. Another similar question on the same board for Dr. Lynch is, if you have a patient who has large hiatal hernia on a barium swallow and Hill grade 4 on your endoscopy, but no mucosal injury, no pectoral stricture, you do a pH testing and the acid exposure time is less than 4%, assuming this is 24-hour pH study, what would you do with this patient?
Depends on their symptoms, I would say. That would be an interesting patient. I haven't seen a lot of patients like that, I guess, with a large hernia, but it really depends on if they have classic symptoms. And sometimes you can see symptom correlation even with a negative AET. So I think in this case, that would play a role as well. I also would make sure and verify the placement of the catheter in that situation if there was a large hiatal hernia. For pH impedance testing, we typically do a manometry to ensure correct placement. But that's one thing I would sort of manually look at the tracings as well. I don't know if Prakash, there's a different approach you take with that, or if you've seen that more often than I have.
I would go with what you've said. I agree with you.
Would you go for a longer wireless pH monitoring?
Beyond 96?
24 hours. No, I mean, assume this was 24-hour study.
Yeah. A wireless, a longer study sometimes definitely gives you more data. The biggest issue with a 24-hour study is that you may catch the patients on their average day, the best day, or their worst day. So if the numbers don't fit what you think the person has, that is when doing an alternate test or doing a wireless test is of value. I think the background here, the starting point has to be, what was your question in the first place? So your question can't be, this person has reflux, let me do a pH study. That is not the question. The question should be, what am I going to do with the results? So in your mind, you should, when you're ordering this test, you should already know what you're going to do if it's positive, what you're going to do if it's negative, and how you're going to handle a test. I think that thought process has to happen before the test is ordered. This is true for every test, not just reflux monitoring, because you'll run into these issues of what to do with the test results when you don't have that clear idea about why you ordered the test in the first place.
Thank you. Another question for Dr. Lynch from Don Selger. Can you please comment on high resolution manometry before with large hiatal hernia? Assuming the question is as a pre-op assessment. And in conjunction with that question, can you comment, can we replace high resolution manometry with video esophagogram?
Sure. So the first question regarding manometry and pre-op workup in a patient with a large hiatal hernia. Typically, we can see the hernia outlined on manometry, but if it's very large, we're getting, when you have that shortened esophagus, we're seeing a little bit more limited data. Additionally, it's tricky with these patients because sometimes you see evidence in the supine position of the IRP greater than 15. And so that would warrant for the updated Chicago classification, upright swallows, you do 5 upright swallows and assess if the IRP was still elevated, because there can be sort of a picture of EGJ outflow obstruction, of evidence of the elevated IRP, elevated from the hiatal hernia. So that's definitely something to keep in mind during that. As for barium swallow, replacing manometry, I don't think we're quite there yet. I feel like barium swallow is a gross evaluation of the patient's motility, but certainly not anywhere near the gold standard. I think it's a good preoperative test because it outlines multiple things, including anatomy, definitely a first look at ruling out other causes. You're making sure you're not seeing a bird's beak, you're outlining the size of the hernia, and then a gross evaluation of motility, but I don't think that that's for that is anything that can sort of replace that. I would see it as more of a non-specific finding that also is variable according to your center. You know, at University of Pennsylvania, even at the different hospitals, the protocol for the barium swallows are different. So it really does depend on your center and the numbers and specific patients you have in high volumes there. I think for the radiologist to be comfortable making certain diagnoses on the barium swallow.
Okay. On the same note, Dr. Gayawali, would you like to comment on the MRS and pre-op multiple rapid swallow on manometry?
Yeah, the multiple rapid swallows are useful if there is borderline or hypomotility on the standard 10 swallow sequence. And if there is contraction reserve, so if there is augmentation of esophageal contraction when you provoke the esophagus, that's what you're doing with the multiple rapid swallows. You are trying to see if the muscle can respond to a stressful situation. And if the muscle responds, it means that when you put in another stressful situation for the esophagus, which is anti-reflux surgery, it's probably also going to respond. And the person is not going to have motor dysphagia. So I use multiple rapid swallows in that context. There's no point looking at multiple rapid swallows if the 10 swallow sequence is normal. It doesn't give you any additional information there. But if the person has borderline hypomotility, so has multiple failed or ineffective sequences, and the multiple rapid swallows demonstrate no augmentation, I think those patients are at risk for having motor dysphagia if they get a full wrap, if they get a 360-degree wrap. Multiple rapid swallow responses, the contraction reserve seen on multiple rapid swallows has also been linked to lesser or lower acid burden in the esophagus. So absence of contraction reserve can be associated with more prolonged clearance times, especially in the upright position.
Thank you. The next question. What's the cutoff do you use for doing pH study on PPI for somebody who has refractory GERD? Is acid exposure time more than 6%, too much or too less?
That is again a very fine question. Very, very good question. Very 2021. I'll tell you why. We have an abstract on this in DDW, and we are currently analyzing studies from patients who are tested on PPI and trying to define what the right threshold is that defines symptom outcome. So improvement versus no improvement. I can tell you from our preliminary information that that number is probably going to be about 2.5%. Okay, that's the 95th percentile of acid exposure time in patients on BID PPI who did not respond on that other study that I mentioned, the MSA versus BID PPI study. Now, if you take healthy controls and look at their acid exposure time on PPI, we have a small subset. We have about 50 or 60 patients who have been studied on BID PPI, healthy individuals. Their acid exposure is near zero. So there is something about these patients who don't respond to PPI that their gastric acid burden is actually probably higher than the healthy control. And I think the part of this assessment, pH assessment that might be useful in those patients, those refractory GERD patients studied on PPI, might actually be the gastric, assessing how much the gastric acid is suppressed with the BID PPI. So if suppression is incomplete, those patients are clearly going to have higher esophageal acid burden. And that's something considering looking into. There aren't that many patients around the world. We've actually queried a lot of utility labs. There aren't that many patients who have been well characterized, who've been studied in that fashion. So proven Gerd otherwise, who've been studied on PPI subsequent to that and have not responded or have responded, where that response is again characterized using validated questionnaires. So we've managed to find about 40 patients from multiple centers. And I think that's going to be the basis for what that threshold is going to be. And my guess is it's going to be about 2 to 2.5.
That makes sense. Thank you. I'm going to go for the next question. This comes up often in clinical practice. The question is, if patient has abnormal acid reflux time of acid exposure time more than 6%, but do not have symptom correlation to extraesophageal symptoms like cough, do you feel confident that this cough is from GERD? That's a question.
You want me to answer or Chrissy?
I guess both of you guys can take a bite on it.
So I tried to answer that online, but I think the person asking this question is correct. You can't really say that the symptom is not related to reflux. I don't think you can say that because reflux symptom association by itself is not a great metric. As you saw from my presentation, the metric cannot function as a standalone test, and it is subject to a lot of variables, including the patient pushing their button in time, not pushing their button. Cough is notorious because it can come in bursts. So does the patient press their button once or 3 times if they cough 3 times? So there's a lot of problems with that. So my approach to that is atypical symptoms are very often from hypersensitivity, throat clearing, cough. You know, these may be hypersensitivity related symptoms. But if you have acid exposure time more than 6, you are justified in escalating reflux management. So if you have acid exposure time more than 6, especially if you have other features, if you have a small hernia, if you have high reflux episodes, you are justified in elevating the acid exposure. I just tell the patient, I don't know if your cough will get better, but you have enough reflux that we can escalate your management. But whatever that escalation might be, you are justified. You can move in that direction and tell the patient there's a chance you won't improve. If you don't, we will give you neuromodulators.
Yeah, I remember one of the talks in last for AFS meeting about you need only a couple of refluxes to have cough for the whole week. So cough particularly is notorious to not have that correlation compared to heartburn or chest pain or regurgitation. Thank you there.
I think
have
that,
one question from
just a comment, that can be really tricky. And I find that the rare patients who we actually do multiple pH impedance tests do end up being those patients with atypical symptoms, like not necessarily cough, but like ear burning or non-specific ENT symptoms. When it's positive, I'll put them on the PPI, and oftentimes it doesn't improve that symptom. And when it's an atypical symptom, I end up repeating it on therapy, which is sort of rare, but that's like a situation where I do see that to be useful.
Thank you. We have one very interesting question from Diego Romani. And I'm going to read it out just as it is because I don't understand that well. What about measuring gastric pressure during high resolution manometry? We introduce 10 centimeter more of manometry tube, then I guess inflate to 200 cc or stimulate with 200 cc to measure pressure change. Would it be a parameter to predict reflux if there is elevated intragastric pressure higher than the pressure measured at 3 centimeter above the LES? Anybody?
This is something that that has been looked at, and you know, we and others have looked at this intragastric pressure. It's becoming more and more important because of these restrictive bariatric procedures. Remember, the bariatric patients, the obese ones, are the ones who have elevated intragastric pressure. I don't know that I would do this with insufflation of the stomach. I would do it. I would just measure intragastric pressure with you know, just at rest and see if that predicts reflux disease. But it won't predict reflux in everybody because the mechanism by which intragastric pressure, elevated intragastric pressure, can cause reflux is when it overcomes the barrier of function. So this is going to be in people with a disrupted esophageal gastric junction. So, and that's by the strain mechanism. That is not the main mechanism for reflux. TLESRs are the main mechanism. And now it is possible that patients with elevated intragastric pressure will have more reflux during TLESRs. And that has previously been shown. But by itself, I don't know that insufflation of the stomach will actually give you additional information. So we've tried to increase intragastric pressure using a straight leg raise maneuver where you ask the patient to elevate their leg in the supine position. That way you can increase intragastric pressure. And that does predict reflux, especially if there is disruption of the esophageal gastric junction. But you know, these things need to be studied. So if you have a study going, please report these, because these are very interesting. Physiologic maneuvers during manometry, very, very exciting element. So that's where manometry can really expand beyond what everybody does. You know, the 10 swallow is so 2000s. You know, it's all provocative maneuvers, and for every new provocative maneuver, there is a niche use for that. So these things are all very useful to study.
Thank you. We have an ENT surgeon on the webinar, and they have asked us, they're wondering if you could comment on the setup of hypopharyngeal esophageal impedance pH study for patients with possible LPR.
Chrissy, you want to take that?
Is this for ResTech? I'm not sure if I'm understanding the question correctly, Prakash.
Seems like it.
So for ResTech, we're not seeing significant correlation with the total esophageal acid exposure on esophageal pH testing or response to conventional anti-acid therapy via proton pump inhibitors, is my understanding from the most recent study. I don't know if Prakash, you probably have something more to say.
Yeah, there is more to this oropharyngeal business than what we truly understand. But I think the patients with true hypopharyngeal reflux causing ENT symptoms, so hoarseness or changes in the larynx, are probably not as high as some of the literature suggests. So many years ago, Mike Vasey did a very nice study looking at these ENT symptoms and PPI response, and the number needed to treat there was almost 80. You need to treat 80 people to get one person to respond to a PPI, right? So what that tells me is that these patients probably have a complex mechanism for their symptoms, okay? My mentor, Ray Klaus, we can't question him because he passed away many years ago, but his opinion on these symptoms was that reflux into the distal esophagus can generate a increased perception of upper aerodigestive sensation in certain predisposed individuals. And then they start throat clearing. They start this process of repetitive throat clearing, which can create some changes there, including erythema. And you can break that cycle in some of these patients by using neuromodulators. So my approach to these patients is to look and see if they have other evidence for reflux. This is where a pH impedance study looking at all these additional metrics in the esophagus is going to be useful. So if the esophageal metrics are abnormal, so if there is elevated acid burden in the esophagus, then that gives you that gives you enough justification to escalate reflux management. In the absence of that, I persist with trying to use behavioral methods, treat acid if there is acid in the esophagus, and then see if I can get the patients better.
Thank you. This question is for Dr. Lynch. If a patient has short segment confirmed Barrett's metaplasia with goblet cells, why is that not evidence of clinically significant GERD? What does length have to do with it, especially if it is more than 1 centimeter of disease?
Yes, certainly. We have patients with short segment Barrett's, and that's considered to be from pathologic GERD. But these patients, most of these patients would never evolve towards esophageal cancer. And so definitely a good question, because we know that these patients have evidence of GERD whether or not they have symptoms. But the overall picture is that someone in whom we should be aggressively considering anything beyond a PPI, I think is sort of the bigger question that you're asking. And I think that should be evaluated on a case-by-case basis.
Thank you. Next question I'm going to go is, can any of you comment on which neuromodulators do you use for reflux hypersensitivity?
So the whole neuromodulator thing is a full talk in itself. But many of the SSRIs, the atypical agents, as well as the tricyclics, and even the non-psychotropic agents like melatonin and Riconchito, which is an herb in Japan, and even H2 receptor antagonists have properties in reducing sensation in the esophagus. So the one you choose is the one that is most appropriate for the patient's and their comorbidities. So if you have an anxious patient who's literally climbing the walls, you want to give them a neuromodulator that has significant anxiolytic properties and probably properties to reduce obsessive behavior. Sertraline, great agent for that. If you have somebody with regurgitation, you have somebody who's a belcher, again anxious, buspirone, okay? If they're significantly constipated, most neuromodulators constipate. And so I would choose sertraline or buspirone in those patients. If they have diarrhea, it's easy. Duloxetine, venlafaxine. Those are great agents that have anticholinergic properties that will slow down the bowels. So again, it depends on their psyche. If they're very, very anxious, don't give them Wellbutrin. If they have a lot of sexual side effects, they're not anxious, Wellbutrin is a great agent because it has lesser sexual side effects and less bowel transit abnormality. You really have to, if you're going to use neuromodulators, you have to understand a little bit about these agents and try to understand what their psych status is. You know, you have to get a sense. You know, I don't have a problem asking my patient with refractory GERD, are you the anxious type? Are you the one who's going to look up all these things on Google? If you are, maybe that needs to be treated. I don't have a problem telling patients that. You know, I don't have a problem sending patients for cognitive therapy, which I know will help not just their symptom, but also their anxiety, if there is a component of anxiety. There's a lot of overlap of anxiety with perceptive esophageal disease. And it's worthwhile addressing, identifying that and addressing it. And those patients will usually say they're better. If you use common. This is what I meant by the overlap disorders. There's a lot of overlap of functional disorders and psychotropic illnesses in patients with esophageal symptoms because both are common, you see. Esophageal disease, reflux disease is common. Anxiety is a common disorder, so there will be a lot of patients with both.
Thank you so much, Dr. Gavali. Next question. This is follow-up to the LPR question. There is a growing literature from Europe on double pH impedance measure as a way to diagnose LPR. I think some of us moved away from that, but do you want to comment on that?
My issue is I don't know what to do with the results. I don't know what to do with the results. I know what to do when I see elevated acid burden in the distal esophagus. I do not know what to do with some of these neurometrics. And I think ResTech has made us step back a little bit and wonder what exactly we're measuring, because it does not seem to correlate directly with what's happening in the esophagus. So there is more to understand here. I think some of these neurometrics measuring baseline impedance in the back of the throat, to the larynx, you know, some of these neuro evaluation schemes might provide further in the future. But in patients that I see with pure laryngeal symptoms, So people who are referred to me for pure laryngeal symptoms, I take them off their PPI and do a 96-hour Bravo. And if that doesn't help me, I will do a pH impedance study. And I'll have to decide based on the Bravo whether I do that on or off. Sometimes these patients need additional evaluation, but as the evaluation proceeds, I also do management. I give them neuromodulators. If they have high reflux episodes, I give them baclofen. I send them for cognitive therapy. And I must say that, you know, the patients who choose to stick with me, many of them do improve. Not all, though.
Thank you. Another question, should young obese patients with very abnormal acid exposure time on Bravo be treated, even if there are no symptoms?
I guess my question would be, why was the Bravo performed? So I think that if the patient had no symptoms and they had this Bravo, you know, before they came to you, if there was no evidence of mucosal disease or symptoms, it would just be someone to watch. But again, it really comes back to what Prakash was saying. What was the question being asked before that test was ordered? Has something changed since the patient had that test or when they presented for that test?
I think weight loss is going to be, I think that should be a starting point to convince the patient to lose weight. You know, a young obese person, you know, what I usually tell them is their best ticket to a long life is weight loss. Whatever the mode of weight loss might be, their best ticket, if they're young and obese, if they lose weight, they're gonna live long. If they don't lose weight, they will be plagued with all these different obesity-related illnesses. And you know, this might be another marker. The abnormal AT, if the Bravo was properly placed, this might be another marker that they're going to have another organ compromised in the future, the esophagus.
That makes sense. But would you, I guess that answered the question.
Well,
one more question.
Do you put them on a PPI? A PPI is easy to give. Would I send them for anti-reflux surgery? No. If they needed any procedure, it would be a gastric bypass. But I would try and convince them to try and lose weight by other means.
Because the question is, if you have abnormal acid exposure time without symptom, would you expect any complications, peptic stricture, Barrett's esophagus down the line?
Absolutely.
Even if you don't have symptoms.
Absolutely, absolutely. Yeah, there is a proportion of patients who will develop complications. But again, this goes right back to why the study was done. So if the patient had no, why did you place a Bravo? So that is a bigger question for me. What prompted the placement of the Bravo? And that will probably answer the question as to what to do with it.
Okay, that makes sense. We have one more question. I've been trying to figure out who to post to it, but question is, what is the presentation of Gerd in an infant? How is presentation different from EOE in infants compared to Gerd?
My experience would be from my children, so Prakash, I'm going to let you take this one.
Again, I'm not a pediatric expert, but the presentation is very varied, as I understand, and you may not be able to differentiate it from EOE. So these patients, these kids may, children may become irritable, especially if they're infants. They may regurgitate, they may have feeding issues, they may have pulmonary issues, but I can't say that I know all the possible presentations. What I do know is it's not easy to study these infants. They don't tolerate these usual adult type tests very well, and we don't have the wireless option. So it does get a little more complicated than assessing an adult. But again, I'm no expert. So that's the extent of my knowledge. Again, the rest of it I'll have to relate to my children, my own children. And I think I might have forgotten most of it because my kids are in high school now. So
one more question, and this is for both Dr. Lynch and Dr. Gaiwali. And the question is, who do you consider and refer for anti-reflux surgery in general? Is it always proven GERD with abnormal acid exposure time, that is truly refractory GERD, or other considerations such as size of hiatal hernia, age of the patient, degree of hypomotility on HRM? The person who asked the question did apologize that this is out of the scope of this webinar.
No, it's not out of the scope. This is completely in line, because that's why you do these tests. You know, I'm trying to decide what to do with the patient. And in my mind, I know that if the test goes a certain way, then anti-reflux surgery may be an option for the person. So who do I send for anti-reflux surgery? I send the younger patient who has clear proven GERD, who does not want to take a PPI despite all my reassurances. I send the patient who has a disrupted esophageal gastric junction, who has regurgitation. I'm not going to be able to fix that with medicines. Hypomotility is not that big a contraindication, because you can't send patients for partial wraps. You just have to tell them that the fix may not be perfect, but it'll be better than where it is right now. It's important that you consider surgery for the right reasons. The reason for surgery can't be just that the patient has reflux disease. It has to be some component of reflux where surgical management has better value than medical management. Not just in terms of outcome based on what you understand about GERD pathophysiology, but also for the patient in general. So a 60 or 70-year-old with multiple comorbidities, it'll take me a little bit more than what it would take for me to recommend anti-reflux surgery in a 30-year-old, for instance, because I know the 30-year-old has a longer period of time they could benefit from anti-reflux surgery.
Same question for Dr. Lynch. That was about who to refer, but who would you consider, Dr. Lynch, for anti-reflux surgery versus just continue the medical management?
I mean, I would say my answer is pretty similar. First, putting together sort of the overall picture of the patient is not very clear cut. So not just because they're elevated acid exposure, but what are their symptoms? What are their risk factors? What does their hiatus look like? And then looking at the esophageal clearance factors as well. But I agree that there has to be something that surgery offers that medical management can't. And there's a lot of fear of PPIs. You know, it seems to be over extrapolation of, you know, small retrospective data at this point. But I do think that the patient needs to be comfortable with their care and how they're managing their symptoms. And so it's usually an overall conversation, but it is a spectrum of patients. I would agree with Prakash.
Yeah, that's essentially what both of us are saying.
Okay. One more question from a testing standpoint. When you do a pH test off PPI, how long they have to be off for impedance measurement and how long for above wireless pH?
It's the same, 7 days.
7 days.
7 to 10 days. And this person has also asked, can you comment on wireless testing for 48 versus 96 hours? The value is that the longer the study, the more likely it is that if you see a particular trend, that's a reliable trend. If you see more than 2 days with one pattern on a 96-hour study, that is highly reliable for whatever that trend is.
Okay, I was keeping this one for last one because it's a clinical scenario. A 40-year-old man with reflux symptoms, regurgitation, nighttime choking, heartburn, vomiting, dysphagia with pills and solids, no weight loss, barium with 4 centimeter type 3 hiatal hernia, no bird beak, reflux to mid-esophagus, manometer with absent peristalsis, but low LES and residual pressure. Seen me for surgery. Is it GERD or is it undiagnosed achalasia?
You're asking me?
GERD. Yeah.
Reflux. Reflux. This is the person whose hernia needs to be repaired and with a partial wrap, but be very careful about that dysphagia. Might have a stricture at the esophageal gastric junction. Need a good endoscopist and you know, make sure there is no stricture. There's a stricture that needs to be dilated because that dysphagia with pills and steak might suggest that there is something at the esophageal gastric junction. It doesn't need to be, because when you have a 4 centimeter hiatus hernia, esophagogastric junction is looking towards the patient's right elbow. Okay, it's not going to be straight. So that can result in some dysphagia too. But I think this is reflux.
I would agree. I don't often see achalasia in conjunction with the large hiatal hernia, but the manometry pressures are certainly not diagnostic unless for any reason the catheter wasn't through the LES, which can happen in true achalasia, but again, typically not with a hernia.
Thank you so much. And that brings to our completion of first webinar. Thank you so much, everyone, for joining. Thank you, Dr. Gavali. Thank you, Dr. Lynch. We'll hold another one in 2 months' time. And
Thank
this
you for
time on
having me.
therapeutic GERD.
Thank you very much to the AFS, to Subhash, to Kate, to everyone connected with the AFS. This was so much fun for both. I'll speak on Chrissy's behalf. This was so much fun for both of us to prepare, to present, and to interact with everybody. The only thing I'm sad about is I can't see everybody's faces from my screen. But
that's true.
Absolute pleasure. And you know, in the East Coast, it's what, it's 8:30. But
Yeah.
the people on the West Coast still have time for a margarita, so go enjoy yourselves.
Thank you, Doctor.
Thank you, guys. Have a good night.
Good night.